Okay, good morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo naroon. Welcome to our 216th episode of the Health Updates webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who've just discovered us today, welcome po. At sana marami po kayong matutunan sa isa pong topic na hindi po natin masyadong napag-uusapan, pero very important po. And this is on endometrial cancer. It's a silent yet significant health concern. Medyo overlooked po siya despite its increasing prevalence. And we are very, very fortunate. For today, we have a distinguished panel of gynecologic oncologists to help shed light on the latest research, clinical practices, particularly on the surgical treatment po, no? And how we can empower healthcare providers and the public in combating this disease effectively. Pag-uusapan po natin yung iba't ibang topics, risk factors, ano po ba yung nagko-contribute sa development po nito? Are there any lifestyle modifications na pwede pong magawa para po mas bumaba po ang risk of developing endometrial cancer, at ano rin po yung importansya ng mga routine gynecologic exams, pelvic exam, pap smears, gaano po ba ito nakakatulong para po mas ma-detect or ma-identify kaagad yung mga iba't iba pong mga cancer. And then also, yung pong sa title po natin, minimally invasive surgical techniques, laparoscopy, robotic techniques po, no, robotic surgery. These offer numerous advantages over traditional open surgery, including yung mga maliliit pong mga incisions. Hopefully will help us have reduced pain, faster recovery time, and improve cosmetic outcome. So pag-uusapan po lahat-lahat ito para po sa ating topic on endometrial cancer. I'm Dr. Raymond Francis Sarmiento. This is the Health Updates program, and we are very, very pleased to have you for our regular Friday po, no? And as you can see, it's my pleasure and honor to co-host this program for today with the PGH Coordinator for Training, Dr. Marie Dion Sakdalan. Dr. Dion?
Good afternoon, Doc Raymond. Good afternoon, everyone. Welcome po sa lahat. It's been a while and I'm really glad to be back as a co-host of Doc Raymond. And it's a very interesting topic that we have today. And as before, for sure po, we will learn a lot, and hopefully it can also impact on how we look at our health and how we can properly prevent this particular disease that we will be talking about this afternoon. So welcome po to all our participants in the live broadcast of Zoom webinar, and to all those watching live via the live streaming on the TV YouTube channel, as well as on the UP System Facebook page, the TVUP Facebook page, and of course, those watching from the TVUP Signal Channel 101. So as mentioned by Dr. Raymond, we have very distinguished guests for this afternoon, particularly from the Department of OB-Gynecology of the Philippine General Hospital. We have Dr. Reni Vinasikam, who will be presenting the topic, and Dr. Maria Julieta Vihermar, who will be our reactor. So as we keep to the theme of giving you updates on health and maintaining good health, we did a little reformatting by taking a closer look at existing and emerging health problems in the Philippines, like endometrial cancer and whatever else is happening in the rest of the world. So before we dive into our discussion, as in before, we take the pulse of the people on the street about the topic. So Doc Raymond will introduce our POTS, or person on the street video, and what questions we ask our common people. Doc Raymond?
Thank you, Dr. Dion. So, before we dive right into the webinar, we'll set a discussion into context. And before everything else, we'd like to thank the TVUP team for coming up with this production po na very, very maikli lang naman po, but very, very powerful in terms of letting us know what's the baseline knowledge of the common folks on the street. For our interviewees for today, we asked the question, ano po ang narinig na po ninyo tungkol sa cancer sa matris? Ano po ang alam ninyo tungkol sa paano nagpapagamot ang mga pasyenteng nagkakaroon ng sakit na ito? At para po sa mga kababaihan na nasa menopause stage na, sa tingin po ba ninyo ay normal o hindi? Yung dinudugo pa rin po ba kayo kahit menopause na? Please watch this.
Gamutan na pwede kang gumaling kung maagapan na ka.
Tulad po ng karanasan ko po, nagbi-bleeding, walang katapusan na bleeding. Hanggat sinalinan po ako ng dugo, B+, dun sa Eastern Bicol Medical Center po.
Ang cancer sa matris ay nakakaano siya kung hindi natin kaagad ipakonsulta sa doktor yung nararamdaman natin, halimbawa pagdudugo, ay nakakabahala po yan sa atin.
Nung unang sintomas ko po, wala talaga po akong nararamdaman. Tsaka irregular kasi yung aking yung menstruation nung time na yun.
Yung iba po kasi nagdurugo, continuous bleeding, katulad ko, may continuous bleeding, nag-start sa myoma.
Na-diagnose na to matagal na. Noong 2008, niras pa lang ako sa pabelya.
I see.
Tapos, ito, nagme-menopause ako, wala nang tigil yung dugo ko. Umabot ng 3 taon.
Katulad po ng radiation po, nire-radiation po ako sa Manila Doctor Hospital. Ang nangyari po sa akin doon, parang yung mga dating sakit ko po, parang lumabas po. Ayun po, sobrang sakit po yung naranasan ko. Pero nakayanan ko po yun.
Base sa akin, nag-biopsy muna, doon po nakita na meron po akong adenocarcinoma. Then that's the time po na advisean ako ng doktor na operahan ako, rather radiation. So sa ngayon po, i-schedule na ako ng operation ko para tatanggalin at malalaman kung anong stage ng cancer ko sa matris.
Hindi ako kumain matamis, palaging gulay, saka yung juicing, yung gulay, ginujuice ko. Pine-blender ko yun.
Ang usual kasi kung cancerous siya, chemotherapy, tapos radiation, external and internal radiation.
Parang hindi po, kasi may kasamahan po ako na menopause na po siya. Ngayon, binugo siya. Parang hindi po normal kasi katulad din po, cancer din po ang dinalabasan niya. Kaya pag menopause, dapat hindi na po daw dinudugo.
Actually, normal lang yan ang menopausal stage. Meron talaga tayo sa kababaihan, meron talaga tinatawag na menopausal period. Normal lang yan, pero pag exceeding po doon sa months, years ng pagdudugo, ay kailangan po siyang ikukonsulta na kagad sa doktor.
Para sa akin, hindi normal eh. Kasi apektado lang itong mga gawain ko.
Sa stage parang hindi na siya normal kung menopausal, kung menopause na talaga siya, pero kung during menopausal, parang normal pa rin naman.
Kaya kailangan po sa mga kababaihan, pag may nararamdaman na tayo sa katawan natin na kakaiba, ay kailangan pong magpakonsulta na tayo sa doktor dahil ang cancer po sa matris ay hindi po siya ma-diagnose hanggat hindi magpakonsulta sa mga doktor.
Okay, thank you TVUP. Thank you again to our crew for putting that together. Interesting, no, Doc Raymond? These are really patients with the issue of bleeding, and mukhang yung iba on the diagnostic stage, yung iba going in for surgery already. And it's also interesting yung mga impressions nila. Normal ba o hindi na may bleeding pa rin kapag menopause? But siguro what we also want to impart to our audience this afternoon is sometimes we really don't have to wait for symptoms to happen, no? Siguro mas maganda yung proactive na stance, no? Paano ba natin, ano yung dapat natin gawin, lalo na sa kababaihan, pag nandun na tayo sa perimenopausal stage, meron ba tayong pwedeng gawin para maaga ma-detect kung may problema man? And hopefully we can answer those questions. Dr. Raymond?
Thank you, Dr. Dion, and thank you also to the TVUP team. Very eye-opening, at least for us. There are different perspectives that we were able to gather, at least as part of that video. So thank you again for the work that you did. Hindi po madali po kasi kumuha ng mga interviewees, and then you will note that there were those who were willing to show their faces and there were those who were not. So thank you again to the TVUP team. Before we start off our webinar, We just wanted to say that as part of our housekeeping announcement, certificates of attendance, we have sent those out completely for all of our webinars po, no? And as mentioned, those who have watched at least 50% of the webinar duration will be eligible to receive the certificate of attendance. So please let us know if there's any discrepancies, or if you have any questions. Please feel free to email us at our up.edu.ph email address. For our webinar today, we'll have our standard panel discussion format, and after speakers have presented, that will be followed by a Q&A session. So we'll get the ball rolling. Dr. Dion will introduce our main presenter for today.
Okay, thank you, Dr. Raymond. So our main presenter is one of the consultants in the Department of OB, or Obstetrics and Gynecology, of the UP College of Medicine Philippine General Hospital. She's working under the Division of Gynecology. He's one of the most sought after laparoscopists in gynecology. Please welcome Dr. Renny Vina Sikam. Afternoon.
Good afternoon. Hi, Dr. Dion, Dr.
Hello.
Francis. Good morning. Good afternoon. So, may I share my slides?
Go ahead.
Okay, so thank you, TVUP, for this invitation. I'm very honored to be part of this webinar. Okay, let me just enter to full screen. Okay, so for my topic today, okay, can you see the full screen?
Yes, Dr. Sikam, go ahead.
Okay, so as mentioned, my topic for today is on laparoscopy and robotics for endometrial cancer. So just a disclaimer to everyone that the following presentation has pictures and videos of surgical procedures, and this may be upsetting to some of our viewers. So maybe when you see a video come up, you're already warned that it's a surgical procedure. Okay, so just for a baseline knowledge of everyone, so endometrial cancer, or cancer sa matres, is the 10th most common cancer and 3rd most common gynecologic cancer in the Philippines. And it's cancer that's coming from the cells that line the uterus, or what we call the endometrium. So what are the risk factors? These are unopposed estrogen therapy, so those women taking hormonal replacement therapy without progesterone, tamoxifen, obesity, nulliparity, infertility, diabetes mellitus, early menarche, and late menopause. So basically, these risk factors point to a hyperestrogenic state. Now, some of these are modifiable. So when you say modifiable, these can prevent the disease, but some of them are not. So one of the modifiable factors would be obesity. Okay, so is there screening for endometrial cancer? Is there a pap smear that we use to detect early endometrial cancer earlier? Unfortunately, there is no routine screening in the general population. So general population means the ordinary patients without any risk factors. There is no screening. There's also no routine screening for patients with moderate risk. So the patients with moderate risk are those with the aforementioned risk factors. However, if the patient has a genetic mutation or has something called the Lynch syndrome, then we can recommend surveillance of the endometrium by gynecologic examination, ultrasound, and even a biopsy at age 35 or less. So in general, there is no screening for most of our regular patients. So what are the signs and symptoms? So as you saw in the video a while ago, it usually presents with unusual bleeding, spotting, or vaginal discharge. And this is especially notable in patients who are postmenopause. So sometimes our patients forget that if they're already menopause, which is like 1 year of no menstrual periods, they should not bleed anymore. So some patients think that's normal, but actually that is a red flag that something might be going on. The patients can also present with pelvic pain, a mass, or weight loss, and this is if the disease is already in advanced state. So how do you diagnose endometrial cancer? Well, we need a biopsy. So there are several ways to obtain a biopsy. It can be through an ordinary endometrial biopsy using a pipelle curette, and this is done OPD basis without anesthesia. If the patient cannot tolerate this procedure, we can do the dilatation and curettage. And this is what we usually call, or what we call locally as RASPA, and we get a specimen that way. And then nowadays, there's also modern technology in which we put a camera inside the cervical canal, and we get a sample directly from the endometrium, and that is what we call hysteroscopy. So all methods are acceptable in diagnosing endometrial cancer. So once you've diagnosed endometrial cancer through biopsy, what is the next step? So the standard of care for endometrial cancer is extrafacial hysterectomy with bilateral salpingo-oophorectomy, with pelvic and periaortic lymphadenectomy and peritoneal fluid cytology. In other words, we remove the uterus, both ovaries and fallopian tubes. We get samples of the lymph nodes that drain the uterine lining, and we collect peritoneal fluid cytology. And traditionally, to be able to do this kind of surgery, the patient has to have a midline vertical incision. So we have access to these parts of the patient. And how is endometrial cancer staged? It is staged surgico-pathologically, meaning we determine the stage after we have done the surgery, and the specimens are sent to pathology for final analysis. Now, nowadays, there's this, since our topic is on laparoscopy and robotics, what is the better approach? So traditionally, we do open surgery, what we saw a while ago with the midline vertical incision, but there's also this new concept of minimally invasive surgery. Maybe not exactly new because it started in the 1990s, but through the advancement of technologies, more and more procedures can be done in this way. So what is the basis for using minimally invasive surgery for endometrial cancer? So these are the studies done in the past, and the major study was the LAP study in 2009, and these were for early stage endometrial cancer. And that study, the LAP2, showed that there were fewer postoperative complications, faster recovery, less hospital stay as compared to laparotomy because the incisions are very small. However, they showed that the operative time was longer. There was superior quality of life in laparoscopy, and for the oncologic outcome, there was a small difference in recurrence rates. So basically, the patient's survival rates were the same, whether you do open surgery or laparoscopic surgery. So because of these studies, this became the basis for the surgical approach for endometrial cancer. So we have different societies, and these are the ones abroad, and they're very unanimous in saying that MIS should be embraced as the standard surgical approach for the reasons I mentioned earlier. So this is supported by the SGO, the SGO, the NCCN, the ESGO, and locally, the Society of Gynecologic Oncologists of the Philippines support the use of MIS. When the facilities and expertise are available, then LAP should be considered as the preferred surgical approach for comprehensive staging of endometrial cancer. Okay, so when we started this in PGH, we had several criteria, and this criteria we keep using until today. We use this criteria because it's not only safe for the patients, but it helps us make sure that the surgery will be successful and that we don't have to convert to open surgery. So these are our criteria. So we use it for endometrioid type of cancer, the BMI of 35. So 35 is already obese, right? But less than 35, we do laparoscopy. The uterine diameter should be less than 10 centimeters because we usually remove the uterus through the patient's vagina. The uterus should be mobile. The patient should not have cardiopulmonary disease or previous radiation. And the stage should just be early stage. And there should be no lymph nodes, bulky lymph nodes on imaging. So traditionally, we place several trocars. So that's where we put our instruments. So we can either put it in this arrangement here with the camera at the umbilical area, or we can place the camera at the Li Huang point, and we have several trocars, accessory trocars, around 3 or 4. Okay, So this is just a sample of what we do. So ito na yung video disclaimer for everyone. So we do the same procedure as an open. So we do peritoneal fluid cytology, and then we collect fluid for sampling for cytology. Then we can go around, we can check all the abdominal pelvic organs. We can check as high as below the diaphragm and the liver. Then we occlude the fallopian tubes to assure that there's no spillage of the tumor when we do our surgeries. And then we just isolate all the ligaments that we do when we do a THBSO, even in open surgery. So this is the infundibulopelvic ligaments. And let me just move forward. Then we do the round ligaments as well. Then we bring down the bladder. We ligate the uterine arteries and also cut the cardinal ligaments. Then we do colpotomy. So we have a uterine guide, a colpotomy cup, to tell us when we have reached the vagina. And then at the end, when we do all of that, we remove the uterus through the vagina. There. So it just goes through. We don't have to make another incision. Okay, then after that, we also are able to dissect the pelvic lymph nodes on one side. So we can see there already the external iliac vessels. So I'll just fast forward this a bit just to show you the lymph nodes that we've harvested. Then we put the lymph nodes inside a bag. And then this bag, it's a makeshift Ziploc bag, although there are some bags that are commercially available. And we also put it through the vagina. And after that is done, we suture the vaginal vault from the inside. Okay, so everything can be performed laparoscopically. All right, so our first experience was in 2017 to 2019. And this was our very first study completed by our fellow. And we looked at our first 28 patients. So of course, since then, we've done more cases than 28. There was some a hitch because of the pandemic. We had to stop all our surgeries at that time. But after that time, we've already resumed. But this is our initial experience. So for these 28 patients, this is our usual setup in OB-GYN, and I'm assisted by my co-operator, Dr. Benavides. So the mean age of the patients was 46, and you could see the risk factors, as I mentioned earlier. And then the BMI was just 24. We had no conversions, and our blood loss was about 217. Our operative time was about 244 minutes. When we would perform lymph node dissection, it's 235. But if we perform para-aortic lymph node dissection, then it would be about 281. We would have transfusion, and we had 1 vault dehiscence, which was managed conservatively, and lymphocyst formation. And the operative stay of the patient was only 49 hours. So again, this is another video of another technique of lymphadenectomy. Okay. So this video is a video of our para-aortic lymph node sampling. So majority of the patients that we did at the time were stage 1A, but some were upstage to stage 2, stage 3A, and stage 3C2. Some patients underwent observation, radiotherapy, and chemoradiation, and our median follow-up was 13 months. Now, the average hospital cost, and these were for our service or charity patients, was about $1,137. and this was subsidized by the hospital. Okay. So here in the video, again, as we look to the right, we are removing the para-aortic lymph node, which sits on the aorta and the inferior vena cava. There. Okay. So what was the conclusion of our initial experience? So the laparoscopy can be incorporated in the treatment of endometrial cancer in our local setting. We only had a few complications and no conversions because we had the strict criteria for patient selection. Cost is a limiting factor, and long-term outcomes and comparisons with open surgery can be studied in the future. So that study is, we still have to do that study in comparing our experience for open and lap. So how about robotic surgery, which is also my topic? So the advantages of a robotic approach is that it employs a three-dimensional view, and there's better and more precise visibility of the operation area. And because of the robotic hands, it helps the surgeon to be less tired, and there is greater mobility and range of movement of the instrument itself. So like if you imagine laparoscopic surgery, it's like it's mimic to the movements of using chopsticks because they're like straight stick surgery. But when you use a robot, there is like a wrist in the equipment, so there's greater range of movement. And what's also different is that you have a binocular view of the field, and as I mentioned, it is 3D. You see it in 3 dimension, like in open surgery, not like in laparoscopy where it is just a 2-dimensional view. And what's also very enticing in robotic surgery is that the learning curve is faster than conventional laparoscopy, and suturing can be adopted faster. So it's easier for open surgeons to transition from open surgery to robotic surgery rather than from an open surgeon entering into laparoscopic surgery where the learning curve is quite steep. Okay, so what happens in robotic surgery? So there is a surgeon-operated console with stereoscopic viewer and hand-foot control. So this is the surgeon seen on the left side. And then the surgeon looks at the field with 3D imaging, whereas the patient is beside the robot, and there are 3 or 4 robotic arms with swiveling instruments. So in this picture, this is Dr. Domingo, our previous chairman of the department, and this is our reactor, Dr. Hermar, who is beside the patient. Okay, so the initial PGH experience was published in the Philippine Journal of Obstetrics and Gynecology, and this is by Dr. Domingo and Dr. Patrick Padilla, and it documented the 7 benign cases of robotic surgery. There was an average blood loss of 576. There were no conversions. So, of course, at this time, it's also the learning curve when this study was published. So for gynecologic oncology, the program was started in March of 2023 when we were trained by the hospital, myself and Dr. Benavides, in robotic surgery. And you can see here the director of the hospital and our current Dr. Gap Legaspi and our current chairman, Dr. Habana. Okay. So this is our typical patient. So these are, as I mentioned earlier, the risk factors for endometrial cancer is obesity. So we get many patients who are morbidly obese. And for that reason, we have thought that the best approach for this patient is the robotic approach rather than the open surgery or laparoscopic surgery. So the Society of Gynecologic Oncologists of the Philippines has made a statement, and it says that robot-assisted lap surgery is a safe and effective alternative to conventional laparoscopy for endometrial cancer staging. There are no advantages regarding the oncologic outcome, meaning the survival of the patient is the same, whether it is laparoscopy or robotics. And we see that the main advantages are short-term, and the clinical outcome shows there's slightly decreased blood loss and length of hospital stay in patients who underwent robotic surgery. So parang mas less pa yung blood loss sa robot and less hospitalization. Now, the advantage of the robotic approach over the lap technique is more pronounced in obese patients. So that's why we are employing that approach for our patients. However, robot-assisted surgery, the cost is greater, and since the machine is not present in all centers, there might be very limited access in the local setting. So this is just a table of our first 18 cases, our first consecutive cases of robotic surgery for endometrial cancer. And you can see in this table, so in the beginning, we were doing it since we were on our learning curve. We started on the patients with a BMI of 19, 29, 24. And then you could see that this is our operative time, so it's still quite long. So you can see in this table, there's 7 hours, but our blood loss is quite little, like 100 to 200. And then this goes on in the next table. So we are starting to do cases who are morbidly obese. So you can see the range of the BMI of the patients. You see here 37.2 and then 55.7. And the blood loss remains minimal. Okay, so this is also another table showing continuation of the table, which shows that our selected population are patients who are obese and our blood loss remains minimal. So this experience is like our first initial data, and in the future we plan to accumulate all these. Right now, I think our running tally is about 23 cases, and in the future we plan to document and publish these cases so that we can share them with everyone. So this is an example of a robotic surgery. So just to demonstrate how it is being done. So we saw a while ago the procedure where we ligated the infundibulate pelvic ligament. So here it's the same thing on the right side. And if you notice the movement of the robotic arms, they're able to rotate in several directions. And so it becomes easier for the surgeon. So this case, I think maybe it might not be a little bit technical for everyone, but this case was one of our cases with a very high BMI. So you can see that the bowels are really in the way. So we need a laparoscopic endofan, and the endofan is held by the assist. You can see the bowels are like just in the back, but still we are able to do the surgery robotically. So these are the same steps, this time being done on the left side, and sometimes we use also the advanced bipolar equipment that we also use in laparoscopic surgery. So let me just fast forward this. So this is the colpotomy, as you saw in the lap surgery. And then we can also suture it in the same way we do the the lap surgery. So the suturing is easier because you're able to move the instruments easier as compared to laparoscopy. Okay. So we're also able to do lymph node dissection in robotic surgery. So that's on that side. Okay, let me fast forward it too. Okay. Okay, so the same steps, and I think it has a better view when we do our laparoscopic surgery. Okay, so at the end, this is what it looks like. So if you looked at our picture a while ago, there was a midline incision. So this is what it looks like immediately post-op on the left, and on the follow-up, these are the incisions of our endometrial cancer patient. This is our current team of surgeons. So we have Dr. Benavides, myself, and our younger consultants, Dr. Mendoza and Dr. Onglao. And because of this, because of the number of trainers that we have, we're also able to teach our fellows this so that in the future they will be able to do it for more patients. So this is my last slide, and this is a letter that I got before. Allow me to be a little bit sentimental at this time. So this was in 2010, and this is when I was applying for fellowship in this subspecialty. And I got a letter from our esteemed mentor, Dr. Augusto Manalo. And in his letter, he wrote there that laparoscopic surgery for gynecologic cancer is still in its infancy in our country. And this is a very sad fact considering our institution is a national referral center. Most of our patients are poor and cannot afford the expensive laparoscopic procedures. It is hoped that we would bring down the cost after one of us have been trained in the procedure. This, of course, will come after our institution has invested in the equipment. So now it is year 2024, and I think from this letter back in 2010, we can see that the hospital has invested in the equipment and people have been trained. And so right now we can offer this procedure, the standard of care, to our patients in PGH. So thank you.
Thank you very much, Dr. Reni, and congratulations for the outstanding and very valuable work that you've done, no, in the past 10 years, and the experience you have gained for the division and of course for our people, no. And it's really nice, no. With this standard approach, we are able to move our patients back to their productive state. No? They can go back to work, they can go home right away from the hospital, and then start anew in terms of treatment if there is additional treatment necessary, or they can go back to work and be more productive again. So thank you, Dr. Reni, and maybe we can call you back again later after we have listened to our reactor.
Thank you.
Okay, so we'll move on to our reactor, and I'm very much privileged to introduce to you Dr. JJ Hermar, as we call her in the hospital and in the UP College of Medicine. She's the past president of the Society of Gynecologic Oncologists of the Philippines, and she's currently the vice chair for academic affairs in the Department of Obstetrics and Gynecology. She's also the head of the Clinical Simulation Laboratory of the UP College of Medicine. Please welcome Professor from the Division of Gynecologic Oncology from the Department of Obstetrics and Gynecology, Dr. Maria Julieta V. Hermar. Good afternoon, ma'am.
So thank you very much, Dion. Good afternoon to everyone, and thank you, Dion, for that kind introduction. And before anything else, I'd like to congratulate Dr. Sikam, Reni Sikam, for the very beautiful presentation. She made it simple for all of us to understand. And more importantly, more than the presentation, I'd really like to congratulate her because this is her passion. So from the time 14 years ago when Dr. Manalo recommended her, she's done well, and she did what she said she would. She came back, she taught our fellows, and in fact, she didn't mention this, I think, but she formed the minimally invasive gynecologic oncology group, so that after teaching our fellows, she will also teach us, the gynecological oncologists, and we could make this available in all parts of the country. So my reaction will be very short. So Rennie told you everything that's essential, but I think just to tie it all together, from the very start when we were interviewing, no, so the patients and the lay people about endometrial cancer, I'm very happy that it came out that really we should be aware of that there is such a disease, and that the symptoms are things that we can notice, and that's something that we should be consulting for, no? So pag merong dinudugo, madalas kasi yan, no? So when we see patients in the clinic, they have been bleeding for quite some time, pero yun na nga ang iniisip nila kapag nagme-menopause, or madalas na yung naglalayag na sa Tagalog, no, yung menopause. Ang iniisip nila na minsan nagbabawas daw, so mas malakas yung regla, when in fact kabaliktaran, no? So dapat kung malapit na mag-menopause, yung madalang na o malapit nang maglayag ang regla, mas madalang at mas konti na. So yun yung mas normal. And then kapag nag-menopause na, ibig sabihin nun wala nang regla for at least 1 year. Kapag biglang dinugo ulit, magpatingin ka agad kasi kailangan nating malaman na hindi nga ito bukol sa matris, no? So endometrial cancer. And I'd like to emphasize what Rennie said, no? So for the longest time, ang ginagawa po namin ay surgery or primary surgical approach. Ibig sabihin kapag po may cancer sa matris, kailangan matanggal ito. Dati yung open surgery or yung nakita nyo po yung pinakita ni Dr. Sikam na ang haba po nung tahe, ano, ganun yung usual. Pero yun nga, ang maganda ngayon, ang standard of care ay ito ng minimally invasive, whether we do it by laparoscopy or yung robotic surgery. And ang importante sa sinabi ni Dr. Sikam, and I'd like to emphasize that, yung careful patient selection, na hindi lahat ng pasyente basta pwede natin gawin yung laparoscopy or robotic surgery. Very carefully selected cases at inisa-isa nga niya po yun, no? At kung naman nang sasabihin natin, ano naman yung mga pasyente na mas mag-benefit from robotic surgery, ito naman yung sinabi niya ng mga obese patients or medyo po malaki po sila. So mas safer po sa kanila yung robotic surgery. At yung isa po ay Dr. Sikam, yung pagkukumpara ng cost, no? So paano ba pag open, paano ba pag by laparoscopy, paano po ba pag robotic, no? Kasi yan yung madalas na katanungan din sa amin. Ang maganda din na ma-emphasize natin, yun nga po yung sinabi po ng aming mentor na si Dr. Augusto Manalo 14 years ago nung kanyang nirekomenda si Dr. Sikam na sana balang araw meron na siya dito sa ating ospital na isang National Referral Center. At ito rin yung kahani din po ito sa sinabi ni Dr. Director Gapri Gaspi noon, nung syempre marami nagtatanong bakit tayo may robot, no? So bakit kailangan nating bumili ng ganun. Ang naalala ko yung sinabi niya na ang gusto niya kasi yung kung ano yung available sa isang CEO o mayaman na tao, dapat available din siya kahit sa vendor, tricycle driver, o kung yung mga simple nating pasyente na nasa PGH. So, yun yung gusto ko rin na magandang sinabi ni Dr. Sikam na yung standard of care, meaning yung dapat na binibigay natin at nakita na natin na ito yung mas safe, mas maiksi yung hospital stay, less yung bleeding, na magawa rin po yun ngayon, available na po siya. Atin yung robot o yung mga gamit pang laparo, nakita nyo naman po yung team ni Dr. Sikam, silang nagawang kaso at naipakita na rin na size, no? Meron po madali at alam na po natin paano siya standard of care ngayon na available sa ibang bansa at sa mga private hospitals. Meron na rin po sa Philippine General Hospital at available po siya para sa ating mga pasyente. Yun lang po.
Okay, thank you so much, Dr. Hermar. Thank you also to Dr. Sikam for earlier po. No? We'll just take this opportunity before we proceed with our question and answer. I'd like to greet those who have joined us, our masugid po na mga taga-subaybay. These are really strong supporters po of the program. Those are watching us from the Mayor Hilarion A. Ramiro Senior Medical Center in Osamis City, Misamis Occidental, Oriental Mindoro, Provincial Hospital in Calapan City, Oriental Mindoro, Camp Navarro General Hospital in Zamboanga City, Zamboanga del Sur, St. Elizabeth Hospital in General Santos City in South Cotabato, and the Department of Social Welfare and Development, Haven for the Elderly po, in Tanay Rizal. We are really working to get more and more people, but those who are joining us, Marilao Bulacan, maraming salamat po. Bataan, University Rizal System Health Services Unit, thank you so much. Los Baños, Laguna, Rizal Medical Center, obviously, we are very, very thankful. St. Paul Clinic also, and then internationally, and Hospital ng Binyan, thank you so much po. Those who are joining us from Ryan Hall Shanex Incorporated in Bridgewater, Canada, Chonin Hospital in Taipei City, Taiwan, Nam Canto University Hospital in Canto City, Vietnam. Thank you so much. From Timor-Leste, maraming salamat po. And then University Fail in the Kingdom of Saudi Arabia. We'll call in po, no? I think nagkaroon lang po ng technical difficulty si Dr. Hermar. We'll call in Dr. Reni Sikam po for our question. Dr. Dion will ask the first question, although I have two that's in my pocket po. Over.
Okay, so yung first question will tackle the one in the Q&A box from Mr. Joseph Tortona. Very masugid to na watcher ng webinar, very much every Friday nandyan siya. So ang question niya, Doc Renny, is, in case of power outage, won't the instruments being used need rebooting? Or are they powered separately from utility power companies to ensure a smooth operational capability?
Okay, thank you. That's a very good question. So the robot machine has like a built-in battery, so it can survive without electricity for about 15 minutes. And then that's the time when we stop the operation and we can undock the robot and also the instruments. So that's the safety feature. And then if we're assured that, for example, the hospital reverts to the generator and we're assured that the power supply is stable, then we can resume the surgery by redocking and placing back the instruments. But if we're not sure anymore, talagang nagpa-fluctuate, then we have to discontinue and convert to open surgery. In our experience, it has happened, no? We had to undock, but we've never had the time that we had to convert just because of the power outage.
Okay, thank you. Doc Raymond, before you ask a question, Doc Raymond, may nakalimutan ka, meron from USA. We have
meron pa? Okay. Thank you.
here from California. So good
From California. Okay.
or good evening to you. Yeah.
Okay, thank you again to our avid viewers po, no? Thank you so much. A question, I'll pose this to Dr. JJ Hermar. I think just because there's a proliferation din po, probably it's coming in from outside the Philippines po, this question of direct to consumer po ng mga genetic testing, yung mga ganun po, no? There are those that are commercially available. Do you think that's something that they should explore in terms of genetic testing, maybe their daw po, no, their likelihood of developing endometrial cancers? That's something that they should look into daw po.
Okay. So ngayon, yung genetic testing na sinasabi, no? So there are people, I know that it's being offered, no, sometimes even abroad. Here meron na rin eh. Generally what cancers, no. So as of now, for endometrial cancer, even for specifically for endometrial cancer, there's no screening test. There's no like genetic test, except that if you have a risk, no. So for example, we're looking at Lynch syndrome. So for example, there are cases of endometrial, colorectal cancer in the family. So these are for populations where yung pupunta sila sa amin and then we will check and then we will check for the risk. No? So there are tests specifically for that. No? There are syndromes that would be. Pero yung generally, like if you go, like tapos sasabihin lang sa'yo, kailangan mo tong mga tests na to know your risk, then we don't advise that yet. No? So in fact, there's no screening test, whether it's a genetic test or a diagnostic test that you can do. No? So on the other hand, when you're diagnosed already, there are molecular tests that we do now that will make us tailor your management based on your results. So iba naman yun. No? So pero in general, yung mga tests na para malaman lang yung risk mo, wala pa tayong sina-advise na ganoon.
Thank you, Dr. JJ. Question? Do you have a question, Dr. Dion, on your end?
Not yet, but ikaw muna, then
Okay.
I'll
Okay. So question here, I think probably they're experiencing it in sa kanilang families. Dr. Sikam, are there any daw po patient groups or maybe support groups that they can join for endometrial cancer so that they know? I think they recently diagnosed po kasi.
Okay. I know in the Cancer Institute in Philippine General Hospitals, there's a cancer survivor group, but it's a cancer survivor in general. None yet yung specific na endometrial cancer that I am aware of, but maybe with the lay they have. But in general, to name one, I cannot name one. But there is a cancer survivor group in the Cancer Institute.
Okay. Thank you, Dr. Sikam. There's one, Dr. Dion, maybe you can ask this po in the Q&A box.
Yeah, anyone can answer actually. So the question here is on the symptoms of endometrial cancer. Is it possible to have menstruation or maybe bleeding after 2 years na hindi na nire-regla? So this is exactly what Dr. Renny was saying earlier and Ma'am JJ. If it's normal and if it's not, what test to conduct or where to go? And this is very practical question for a lot of our audience. Yeah.
Okay, so as I mentioned earlier, so first we have to note that menopause is 1 year of no menstruation. So if you already have 1 year of no menstruation, you're considered menopause already. Then if you bleed after that, that's already a red flag. No, you really have to consult a doctor already. It doesn't mean that it's cancer right away, but most of the time it's not. Actually, there's an entity called atrophy. So maybe the endometrial lining baligtad is very thin and the patient will bleed. So it's most can be that. But you have to rule out that it's not cancer. So una, wag mo na matakot kasi baka matakot, ay cancer na agad. Parang pwede namang hindi, pero dapat magpatingin. And usually your OB/GYN will request for a transvaginal ultrasound if you've had sexual contact already, or if you've had like children. That's what we usually request for. If wala naman, we can do transrectal ultrasound. And that's when we can see very clearly the endometrial lining. This is performed by OB sonologists. And we have a cutoff for menopausal. So just to mention, if it's more than 4 millimeters, then we think na posible na there is a pathology. And that's when you will undergo either what I mentioned, the endometrial biopsy, or a DNC, or hysteroscopy, because that's when we have to get issues. So to answer our caller's question or our watcher's question, you have to consult an OB/GYN who will probably do an ultrasound and you will probably undergo a biopsy.
Okay, thank you. And everywhere, mula north to south, maraming OB gynecologists.
Maraming guide.
So, wag matakot kung meron ganung pagdurugo, but wag rin maging wag rin maging panatag ang loob, no, na okay lang 'yan. So, that's as mentioned, yun na po ay red flag, so might as well consult the doctor, your friendly doctors and OB gynecologist para magawa na agad ng paraan, no? What else? Doc Raymond, do you have anything more?
Siguro I'd like to
No, I
add,
think that's the last one, but Dr. Sikam, sige, go ahead po.
I just want to add, kasi parang we mentioned earlier, not like cervical cancer. I know you had the webinar before on cervical cancer. So yun yung pap smear, yung screening with HPV DNA test. So yung endometrial cancer, wala siyang screening. So ang important fact doon, the symptom talaga. So the patient has to be aware na may abnormal bleeding siya. Kailangan magpatingin siya sa doktor kasi wala siyang screening, hindi katulad ng cervical cancer na may pap smear, may HPV DNA test, ang endometrial cancer kasi wala. So kailangan alam ng pasyente yung katawan niya, tas mindful siya dun sa mga symptoms. Yun lang po, Doc
Doc
Ray.
Raymond, merong pahabol.
Sige, ma'am.
Yeah, so ang question, on the other side of the line naman, knowing that you're already menopausal and maybe mas may risk ka na to have this problem, pwede bang magpa-ultrasound kahit walang nararamdaman?
Well, ano yan, yung sabi nga ni Renny, di ba? So pag after menopause at nag-bleed ka, maganda magpakonsulta. Kasi nga, we can use the ultrasound to triage. Manipis ba sobra? Kaya ka dinudugo. O kung medyo makapal, above nga 4, no? So doon yun yung biopsy. Pero yung sabi ka kanina ni Renny, di ba? Wala naman talagang screening. No? So, hindi natin gagawin yung ultrasound para lang malaman, no, kung wala naman silang nararamdaman or menopause sila. Pero of course, even when you're menopausal, you have to see your gynecologist, di ba? Kahit every year for the regular checkup. And then she will determine whether you would need an ultrasound for other causes. So, siguro dagdag ko lang din na common siya sa menopausal or post-menopause na nagbe-bleed, pero kahit na yung nagre-regla pa, kung na-mention na rin naman to ni Renny kanina sa kanyang lecture, kahit na yung abnormal bleeding lang, ibig sabihin, in between ng menstruation, nagsaspotting ka o nagbe-bleed, o kaya naman, unusually malakas. No? Minsan meron ako mga pasyente, sasabihin nila malakas, hindi naman po malakas. Pag tinanong mo, gaano ka sa isang araw, ilang pads, minsan sasabihin nila, 5 baby diaper po. Hindi na yun normal, no? So yun yung mga abnormal bleeding. Pag nag-iba yung regla mo, mas maganda magpatingin, no? Kasi nga yung mga sinabi ng ni Renny na risk factors, kung meron ka nun, plus nagbe-bleed ka, maaring mag-investigate further pa yung gynecologist mo kasi nga baka at risk ka for endometrial cancer.
Thank you, Doc JJ. And I think very important yun. Hindi lang perimenopausal women ang at risk, no? Pwede pa rin kahit regularly na nag-menstruation pero may mga abnormal na bleeding in betweens or sobrang lakas, dapat mag-consult kasi hindi siya normal. Okay, very very valuable yung mga insights, no? Ako naalala ko na yung mga naturo sa akin during my OB rotations and parang maybe we can also share this new knowledge to our colleagues and to our patients that we see every day in the clinics. Thank you very much, Dr. JJ and Doc Renny.
Thank you.
Maraming salamat po sa ating mga gynecologic oncologists from the Department of OBGYN at the Philippine General Hospital, Dr. Sikam and Dr. Hermar. At this point, we'll be launching our evaluation poll. It's 5 questions. 5 statements po, and then we just put in like a 4-point Likert scale from strongly agree, disagree, and strongly disagree. I'll read through them and then we'll just keep them open till the end of the webinar. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language and technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we encourage everyone to input your or feedback for today's webinar. What is our topic for next week, Dr. Dion?
Yes, next week we will be talking about cancer pa rin, but now it's among children. So stay tuned. Please be there again. We'll see you again next week. It's going to be an equally interesting discussion.
Thank you, Dr. Dion. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. So you just go to www.youtube.com/TVUPPH. And then in the live tab, you'll be able to see all of our 215, after today, 216 webinars po, no? And then you just go to another tab, which is the shorts tab. And because we understand everyone very, very busy, so we have prepared selected presentations, just snippets of them. And we hope you'll be able to pick up nuggets of wisdom from those selected short presentations. Okay? So this formally closes our webinar for the week. Makita-kita po tayo ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
Have a good weekend po sa lahat and keep safe, keep healthy, and see you online.